Good afternoon, everyone. My name is Adiba Kamarul Zaman. I'm a professor of medicine and infectious diseases at the University Malaya Medical Center and at Churia, as well as president of the International AIDS Council. It gives me great pleasure to welcome all of you this afternoon, to a follow-up meeting of the IAS Educational Fund to the one that we had last year here in Kuala Lumpur. Today's webinar is entitled Overcoming Challenges in HIV with Science, Innovation and Collaborations in Southeast Asia. The aim of this meeting is to present the progresses made since our last meeting, and the topics we will cover today will be on HIV self-testing and Chemsex, PrEP, and COVID-19 and HIV, considering where we are with the two pandemics at present and its impact on key populations. It gives me great pleasure to introduce our lineup of speakers, all of whom are dear colleagues of mine. Dr. Howie Lim from the Department of Social and Preventative Medicine and Churia, Mr. Yusral Yusuf, the Technical Manager at the Malaysian AIDS Council, Associate Professor Iskandar Azwar, here too at the University Malaya Medical Center, and Mr. Michael Kessel, the Senior Technical Advisor with FHI 360 and linkages, as well as EPC in Vietnam. The aim of this IAS Educational Fund virtual meeting is open free to colleagues all over the Southeast Asian region, HIV professionals, as well as key populations. And we hope to provide targeted and inclusive educational opportunities for healthcare workers, researchers, advocates, key population representatives, and policymakers to help strengthen action in national programs in regional contexts based on latest scientific evidence. Now, we can start off the meeting with a presentation from Dr. Howie Lim, who will discuss an integrated self-testing service delivery program called JOM Test for key populations and a randomized controlled trial of an online intervention to address chemsex among men who have sex with men in Malaysia. Howie, the floor is yours.
Hi, good morning and good afternoon. My name is Howie Lim. I'm a senior lecturer of the Department of Social Preventive Medicine of Faculty of Medicine at University of Malaya. I'm here to share with you an update of what has transpired after the IAS education workshop that took place October last year in KL. Okay, so I'm here to present to you two projects that I'm undertaking. The first one is the HIV self-testing service delivery program in Malaysia. It's called JOM Test. So this project is a collaboration with Malaysia AIDS Council, La Foundation, and Yale Universities. So this is the protocol of the study, and is based on a very similar study that was done for MSM living in Queensland, Australia. All right. Okay. So I'm going to guide you through this flowchart. So the recruitment is done through several methods, from word of mouth, gay apps, non-social gay apps, and also through the promotion by the HIV organizations in Malaysia, and also as well as Facebook. All right. So from jomtest.com, this website, participants can first give us the online informed consent after they have read through the protocol, so they understand the procedures. And after that, they are going to take this pre-test survey. Okay, this pre-test survey, which I'm going to show you later, will have questions about sexual behaviors and also testing history. Okay, so after that, they will give the website the informations some personal information such as email address, phone numbers, and mailing address, so that the test kits and packages can be sent to their preferred address. All right. And the pre-test information is available online on jomtest.com and also in the test kit package. Okay, so after receiving the test kits, participants will have to do the testing by themselves. Okay, so if a test reactive, if they have the reactive test, they'll be able to share the results by uploading the images on the website. Okay, and after that they're gonna take the pro-test survey. Okay, so those who test positive or reactive, they will be they'll be asked to access the confirmatory HIV testing. Okay, and if they really have a true reactive test, they'll be supported through the peer navigation system. Okay, that exists in the currently in our system. Or if they test negative, they will have the opt-in options for the test reminders. Okay. All right. Finally, at the end, they are going to be certain participants are going to be invited for in-depth interviews to evaluate the whole testing program. So to be eligible for the study, participants have to self-identify as MSM, men who have sex with men, transgender women, sex workers, or their partners. They have to be above 18 years old, currently residing in Malaysia, and self-reported to be HIV negative or an unknown HIV status. So this is the online pre-test that I talked about earlier. So basically, we are collecting information of social demographic information, sexual behaviors with male partners, sexual behaviors with female partners, and also history of HIV testing. Okay. For the sexual behaviors with male sex partners, we also ask questions about the use of crystal methamphetamine and also injecting drugs, which are high-risk behaviors. And this is the post-test survey. So after participants share with us the test results, right? We ask them to do this post-test survey. So basically, we want to know whether they have experienced any social harms that occurred during HIV self-testing. Okay. So this is the front page of the JomTest website, and you can see the image here. So right, the pictures that we used. So it's not just target for MSM. Okay. And if you go to the test kits information website, so currently we have Oral Quick as a test kit, and we are also engaging other HIV self-testing test kits company called Insti, and they are going to sponsor us the test kits. So participants don't have to spend any money. So the test kits are all sponsored by the companies themselves. And we also have fundings from Global Fund to cover the costs of mailing of these test kits to these participants, right? And as I said earlier, there's very clear information on how to use the Oral Quick test kit. There's steps which which is not here, but you can see that on the website. Okay, step 1 to step 4, and how to interpret the test results by themselves. Okay. Just a little bit data on the progress. So the medical ethics approval was obtained in June this year, and since then we have been working on the website itself. So Love Foundation has helped us design the website, and also we were busy on finalizing the questionnaires with our team from Yale. Professor Rick Altis gave us a lot of useful feedback, and we polish and we also pilot test the questionnaires. Okay, so since we launched the website in November, okay, so it just happened, and so far they the response was very positive. So number of participants 439. So those there are 343 participants completed the pre-test survey, and there is a total of 243 self-testing package that have been delivered. And also so 49 participants completed the self-testing and submitted test results. Okay, and among them 3 were reactive, okay, 44 non-reactive, and 90 completed the post-test survey. Okay, so remember that this is a one-year project, and our target is to deliver 1,000 test kits. Okay. So I forgot to mention that the test kits also contain the condoms and lubricants. Okay. So it takes some manpower to package this. So next, I would like to share with you the other projects that I'm undertaking. So it's a randomized control trial of an online intervention to address chemsex among MSM in Malaysia. And this study has obtained the ethics approval from the Medical Ethics Committee at University of Malaya. Just to give you some background on the chemsex intervention project, sexual drug use or chemsex is a growing concern among the MSM communities in Malaysia. And in an online survey that was done in 2016, the prevalence of chemsex among 990 participants was 17.2% in the past 6 months, which was very high. And 6 years ago, I did a qualitative study of stimulant using MSM in KL. Participants told us that under the influence of crystal methamphetamine, so they were sexually aroused, and that were also sexually disinhibited, that often lead to condylence in the intercourse. Okay, so there's implication on HIV, STI, and Hep C infections. From the qualitative study, participants also reported physical mental health problems and also other social consequences. Okay, so we know that also from the feedback from the communities, chemsex is a real problem for these subpopulations of MSM. So we did a community engagement workshop on 24 February this year. So I invited my colleague, Prof. N.E. from the Department of Psychological Medicines. So N is an addiction specialist, and so together we conducted this workshop to the communities, and also try to get feedback from the communities on what should we develop, what kind of chemsex intervention we should develop next. So the learning objective of the workshop is to share with the community members the technical guide by the UNODC and also UNAIDS. Okay, so we share with the communities the basic understanding of stimulant drug use disorders, diagnosis and treatments. So what I really like about this technical guide is that at the back, there are also checklists for harm reductions for policymakers and managers, and also for the stimulant users themselves. Okay, and it's very useful information. Okay, and also participants can also learn the evidence-based psychosocial interventions that address stimulant drug use. So these are the 2 aims for the studies. So as I said, ASSIST is the full name for ASSIST is the Alcohol Smoking Substance Involvement Screening Test. It's developed by WHO. It screened the risk category for more than 10 substances and consists of 8 validated questions. So we plan that there will be training by Professor Robert Ali from University of Adelaide. Okay. And the training of caseworkers or peer counselors will also be evaluated. Okay. So to summarize, these are the online intervention items: the ASSIST DBI, brief interventions. Okay, and we identify caseworkers who can be the peer counselors. Okay, and these peer counselors will administer the brief interventions online with the participants. So everything in this project will be online. There will be no physical interaction with the participants. Okay. So after that, after participants receive brief interventions, they will be asked to do the Chemsex plan themselves. So Chemsex care plan is the self-directed interactive online materials that have been developed by David Stewart, Mr. Stewart from the 5016 Street, London. Okay, it's rooted in motivation interviewing and also based on the lessons learned from the Chemsex among MSM in London. Okay, and for the control group, participants will access and the materials and go through the materials themselves. So this is the study flow chart. Okay, the eligibility will be accessed by phone screen, and also participant will provide informed consent. And after that, they will have to do the baseline assessment, and they will be randomized so to either education group or the online intervention group. Okay, and so after the interventions, there will be follow-up, 2 weeks follow-up, and also 4-week follow-up. We will use e-assist and DAS21. DAS21 is to assess the mental health, stress, depression, anxiety. Okay, and this is the online intervention flowchart. So the brief intervention is based on frame model, feedback, responsibility, advice, menu of options, empathy, and self-efficacy. And for Chemsex care plan, it's really designed to motivate participants. So participants, based on where they are in the stages, okay, of change. So whether they are in pre-contemplation or contemplations. Okay, so we don't force participants to do what they do not want to do. All right. So and there will also be harm reduction informations similar to the ones that exist in the UNA's UNODC guide. So, and also the Chemsex care plan will give information on cognitive scales to prevent relapse. And also there will be risk reduction informations on HIV testings, PrEP services, and also U equal to U to emphasize the importance of treatments. So these are the references, and I'm happy to take any questions that you may have. All right, thank you.
Thank you very much, Howie. We'll move on to our next presentation. Okay. So we'll move on to our next presentation, which will be given by Mr. Yusral Yusuf from the Malaysian AIDS Council, and Yusral will discuss the JOM test and Chemsex online intervention and the knowledge and lessons gained from implementation and community engagement to get this program going. Over to you, Yusral.
Hi, good morning, good afternoon, and good evening, wherever you are. Thank you for joining us today. My name is Yusral from Malaysian AIDS Council. Following Howie's presentation just now, while he touched on the research component of JOM test and Chemsex online intervention project, I will be discussing more on knowledge and lessons gained from implementation and community engagement throughout the development and implementation process of JOM test and Chemsex online intervention project. Before we go further on the HIV self-testing or JOM test project, let me explain where and how HIV self-testing fits in our national HIV program for key population called Differentiated HIV Services for Key Population, or in short, DHSKP. If you look at the diagram, a Jump Test project is not a standalone project because it links with other existing services with outreach points, other testing modalities, and most importantly, linkage for treatment and prevention services, including PrEP. Two things that we learned from this project so far. First, community members appreciate how HIV testing is made easier and friendlier for them. This has been shared widely on our social media platform. Second, it's important to have the linkage mechanism regardless the outcome of the testing results. Especially for those who get their test result reactive, they need to know what to do next and how they can get assistance. So in the website, we provide hotline, which mostly manned by our digital team, who are known by community members through their social media visibilities and engagement. Other than that, we also provide lists of about 300 community outreach workers and case workers in every state in Malaysia. So what we learned in 1 month period of implementation, people do share their results and reach out to get assistance. So for cases like this, the digital team members become peer navigators or first responders and further refer clients to get assistance from our community workers in their areas, provided they agree to get assistance. Otherwise, we also provide lists of community-friendly clinics where they can go directly. As people start sharing their experiences of using HIV self-testing kit on social media and how easy it is, it motivates others to do the same. At the same time, it starts conversation on HIV awareness and the importance of knowing their status. Indirectly, it creates online support groups among users themselves. The Jump Test project was launched in September. However, before we opened for registration, we conducted a dry run for almost 1 month period. About 180 community workers from different key population groups signed up and provided initial feedback. Moreover, we conducted continuous online engagement through daily updates and promotion on social media platforms, on Twitter, Facebook, Instagram, as well as we produce videos and talk shows to discuss about HIV testing and other related issues, hoping that this will normalize HIV testing among community members. In November 2020, this year, we opened the website for wider registration. And in less than 1 month, 327 people ordered test kit via the Jump Test website. So this is very convincing. From Jump Test, we move on to Chemsex online intervention. Over the past years, the discussion around Chemsex was limited. However, I'm glad to see more discussion about Chemsex at different platforms in recent years. Therefore, the Chemsex online interventions that we have, that we are going to implement in December this year, already has gone through series of consultation and engagement with community members, including CAM users themselves, as well as other relevant stakeholders. This includes closed door forum on Chemsex for MSM and transgender in 2018, and as well as IS Educational Fund workshop that was conducted in Kuala Lumpur in October 2019. So from those engagements, some key points are including more information gathering, compilation on Chemsex needed, the need to better enhance linkage and networking, community supports on decolonization advocacy effort, the need to identify key people in the community to be trained as first responders and counselors, public awareness on importance of mental health, information dissemination to the community about drug use among key populations, support in the space, in safe space, including virtual intervention, social media intervention on dating apps for MSM, technical working group Chemsex, involving all interest parties, harm reduction, shrinkage exchange program, spiritual and psychosocial supports, need for specific intervention for youth, and many other inputs as shown on the slides. Therefore, through this Chemsex online intervention, we are trying to address those needs. However, given that this is totally a new intervention, we might not be able to fulfill all the wish lists. But it's important for us to get the expected outputs and outcomes so that it could be considered for continuations after the pilot project. Chemsex requires continuous education, training, and awareness, and other continuous program. So in 2019, in line with the implementation of differentiated HIV services for key population, we produced a self-study and reference manual called Understanding HIV and Key Population in Malaysia, which Chemsex also included in one of the chapters in the manual. And we usually put Chemsex as part of the training module. However, this is not enough. More discussions either online or offline need to take place. For both joint tests and Chemsex online intervention, my key recommendations are, first, intervention need to evolve according to development of technologies and current situations, whether to make it easier, safer, effective, and sustainable, tailored to the need of different target groups. Second, community response through NGOs, CBOs, and other social groups play important roles to build trust in engaging key populations that are already highly stigmatized and criminalized. Third, increase the collaboration efforts between different sectors. This includes civil society organizations, governments, private sectors, research, community leaders, and other relevant parties. Fourth, continuous advocacy effort to break the barriers to services, such as stigma and discrimination, criminalizations, and incarceration. And most importantly, evidence-based interventions should be scaled up and supported at the highest level. This including in terms of funding, in terms of policy to create better enabling environments to increase help-seeking behaviors among key populations, and etc. With that, that's the end of my presentation. Thank you so much.
Thank you very much, Yusral, for that excellent presentation highlighting the the huge needs from the community and the gaps that we will need to fill in order to address these issues. What we're going to do is take a couple of questions before we proceed to the next presentation, and we have one from Jeff Domingo. I think this will be for Howie on the Chemsex intervention program. Was there any challenges faced with regards to the government's illegal drugs policy? And if so, how was this addressed?
Hi, good afternoon. So from now, so far as we plan the project, there's no apparent legal from implementing the study by itself. We know that despite the anti-drug laws, the ATA use is still prevalent, and for us, I think the key to implement this project is to get the trust from chem using MSM in the communities, and we are going to use this harm reduction, non-judgmental approach. And yeah, I hope that answered the questions.
Thank you, Howie. Yeah, so I think if I may step in there as well, a lot of the Chemsex activities are still under the radar, I suppose, when it comes to the law enforcement, unlike street heroin use, which is more visible to law enforcement.
Yes.
So that's another, I guess, way that it's kind of bypassing the law enforcement for now anyway. But we do hear of a lot of raids at even in private parties. So it is something that we definitely need to be mindful of. Yeah. I have a question for you, Howie. The response rate for the pilot project, although overall seems good, but the number of people actually undertaking the testing is not very encouraging. Yeah. So firstly, why do you think this is so? And secondly, what steps can we take to improve that testing rate, which is, after all, the goal for this whole project, to increase testing?
The jump test was just launched last month, right? So we are trying to figure out why that some participants did not give us back the results. And this is actually the research questions, the feasibilities, like which steps along the way on the website would people not go through. So I'm not sure. The answers. But we were trying to actually get some feedback from them, and also follow up with them. To remind them that we have delivered the test kits, and it's time for you to do the test, and hopefully they will remember to take the test and give us the results.
Okay, thank you. I think a lot more outreach needs to be done to improve that testing rate. Yeah. There's a question for you, Yusral. There are other NGOs also doing outreach for Chemsex. Can I know what are the collaborations between them and Max Jom Test? What exactly are the collaborations being done to avoid overlap or create competition between NGOs?
Thank you, Prof, for the question. So this specific question for the Jom test, HIV self-testing. As we know that we're providing different modalities for testing, different modalities approaches for testing. So when we have the community-based testing, it's actually, it has its own strength, where the community members who prefer to be assisted by community themselves to do testing. And another strength for this is for NGOs to go to the sites, to the community members, to different groups of community members. So if we seek HIV self-testing that we're providing is mainly via online, it's accessible via online. And not everybody is actually internet savvy or computer savvy, or have access to internet, everything. So this is where we filling the gaps. So I think there should be no problem in terms of competing among NGOs, as we are complementing each other. So the Jom test has its own target groups, especially people who are online, and then for community-based testing and other facility-based testing that can fill up other gaps that probably we cannot fulfill in the Jump test or HIV self-testing project.
There's another question here for, I guess, both Yusral and Howie, from Dr. Rajesh Gopal from India. Did you have any problems due to lack of effective pre-test counseling in HIV self-testing? What are the mechanisms built in the intervention to obviate such scenarios?
How you like to?
Yeah, I mean, so for self-testings, yeah, it's meant to be self-testing, right? So the instructions are very clearly included in the test kits, and also provide the information on the website.
So yeah, so to echo what Javi mentioned as well, as much as possible, we try to create as much as online information on preparing themselves, getting tested. So those sharings among the community members, and as well as the hotline provided for them, will cater to the needs of the community who would like to get more information. So we receive call from people asking about before they start the testing. They're asking about if they have any concern or anything. And even after the testing, we have people who call to confirm if they're doing right and so on. Other than that, we provide the list of community workers on the website that they can directly contact for more information and for guidance and assistance.
Yeah, that's important. Actually, we do have a list of caseworkers who can answer questions about testing. So this is fallback mechanisms. If they have any more questions, they can ask.
So thank you both. There's a question from Dr. Nitya, and I think we do have an answer to this one. Do you have any data on the preference among Chemsex users on oral fluid versus blood-based HIV self-testing in Malaysia? Howie, you do have some data here, right?
Let me see. We have data, but it's not for Chemsex stimulant using MSM. So the survey that we did was a general survey, MSM survey, not specifically for stimulant using MSM on the preferences of self-testing.
And the answer was?
No. So there was no. So we don't know whether they prefer.
No, even for general.
For general, memory, yes.
Yeah.
It's the finger prick, blood based.
Yes. Yeah, quite surprisingly, Nitya, of those surveyed, I can't recall how many. Howie, you need to help me. 40, but there were more people who preferred finger prick testing rather than oral testing.
Yes. We think that there's a perception, that blood based is more accurate.
Correct. And I think up until recently, we didn't have good access to the finger prick one at a reasonable cost anyway. That's why we went for the oral-based testing, correct?
Yeah, they are all oral-based for now. Yeah.
For now, yeah. But we're expecting to have the blood-based test kit soon, very soon.
Okay, thank you very much, both of you, and we really hope to move from pilot to a full program very soon, because as we all saw from, well, we're still living in COVID era, and around the world, HIV testing has dropped tremendously in both low, middle, and high income countries. So digitization and the use of technology is something that's very important, not just during COVID, but post-COVID, to improve HIV testing. So we do need to, hopefully we'll be able to scale this up very, very soon after learning from these pilots any obstacles that might present, and including at the moment, although there are lots of people registering, the rate of testing is not as good as we hope for it to be. So moving along, our next presenter is Associate Professor Iskandar Azwar, who will be speaking on the pilot PrEP study called My PrEP study, and the lessons learned from the demonstration project. And again, hopefully we can scale this up as soon as possible. Iskandar.
Good morning, good afternoon. Thank you to the organizers for allowing me to present today as part of this IIS webinar. My name is Iskandar Azwar, and I'm one of the infectious disease consultants in University of Malaya. The title of my talk today is the My PrEP study, lessons learnt from a pilot demonstration project and recommendations for scale up. Just the background of my talk, I'll start by talking about the HIV epidemiology of HIV in Malaysia, PrEP timelines within the country. I'll talk a bit about the My PrEP study and findings of the study, lessons learned and considerations for scale up and next steps. So looking at the trend of HIV infection in Malaysia, the epidemiology of HIV in Malaysia was traditionally driven by injecting drug use. But however, over the past 10 years, due to a successful harm reduction program consisting largely of methadone substitution therapy and a successful needle syringe program, the epidemic has essentially is now currently a sexually transmitted epidemic. Over the past 5 years, this epidemic largely has been increasing within men who have sex with men. Now, looking specifically and breaking it down into key populations, we find that HIV prevalence over the past years since 2012 has increased significantly from 7.1% to 21.6% in 2017. This is data which is reported by the Integrated Biobehavioral Surveillance Study in the respective years by the Ministry of Health. When we look specifically at the urban capital, Kuala Lumpur in Malaysia, we can see that the trend now has increased significantly since 2012, about 10.2% to 43.3%. So very significant increase in HIV prevalence. Some of the main PrEP initiatives and timelines in Malaysia have been so far. In May 2016, where we started talking about PrEP, was a national PrEP consultation, which I'll talk a bit about further. And subsequently, in December 2017, significant price reduction of generic Truvada, largely due to the entrance of another provider of generic TDF and FTC. The National Consultation on PrEP really started the discussion of PrEP within the country. This occurred in mid-2016, involved various stakeholders, community members, CBOs, Ministry of Health, ID physicians, primary care doctors, and funders within the region. And the recommendations and essentially what was the outcome of the meeting was that Ministry of Health was supportive of PrEP as an additional HIV prevention tool. They, however, recommended more operational research and a pilot demonstration project to study the feasibility of PrEP implementation in key populations through a number of service delivery models using client-based PrEP. They emphasized non-Ministry of Health settings, so particularly university settings or the private sector. Prior to this, we undertook 2 key studies looking at the acceptability and willingness to use PrEP within MSM. These are findings from a qualitative study from focus group discussions of about 19 MSM, looking at the willingness to use pre-exposure prophylaxis for HIV prevention within men who have sex with men. Now, PrEP uptake is largely dependent on risk perception. And from this study, we found that the majority of people who were interviewed had low risk perception and felt that their current frequency of condom use or being in a monogamous relationship, even though the condom use was inconsistent, was sufficient. Participants did not view PrEP as a means to replace condoms, but rather as an additional layer of protection over and above that offered by condoms. Condoms were often preferred at the time of interview to PrEP because it represented a physical barrier that they could see. With respect to assumptions and stigma, most perceive PrEP as taking responsibility of their own sexual health and their partner's sexual health. However, there were concerns around other MSM perceiving them negatively as promiscuous or wanting to engage in condomless sex. Looking at service preferences, and this is in a quantitative study of 990 MSM online, and looking specifically at the services where they prefer to access PrEP, 22% said they would rather access their PrEP through a community-based organization. This was followed by 21% from a private clinic and 18% from a government hospital and art treatment center. Using this information from both the qualitative and quantitative findings, and also from discussions around the National PrEP consultation, we then went on to develop a pilot demonstration project, which was funded by UNAIDS, WHO, and Global Fund, and partnered with Malaysian AIDS Council. This looked at 150 HIV-negative MSM at high risk of HIV infection who were followed up over a period of 12 months. Generic Truvada-based PrEP was donated by Medispect and Cipla, and although we were not specifically looking at different sites, we wanted to look at PrEP delivery across a HIV treatment center, University of Malaya Medical Center, a private clinic, the Red Clinic, and a community-based organization based in PT Foundation. So 3 different PrEP delivery sites. The overall objective of the study was to evaluate retention, adherence, risk behavior, side effects, STI and HIV infections among MSM taking HIV PrEP, and to document delivery of these services to inform national policy, expansion, and scale-up. So this was a self-selected sample of 150 HIV uninfected MSM at 3 different sites. To be included in the study, they had to be 18 years of age or more, male, sex, Malaysian, living in the Klang Valley for the next 12 months. They had to demonstrate substantial risk of HIV infection, as indicated on the slide. They were excluded if they had established HIV infection, if they had evidence of renal impairment, or if they had adverse health conditions which precluded them from taking PrEP. Generic Truvada was provided for a period of a 12-month follow-up period. Patients were followed up at baseline, month 1, month 3, month 6, month 9, and month 12. At baseline, they had a rapid HIV antigen antibody test, HIV point-of-care viral load, renal function testing, hepatitis surface antigen and surface antibody testing, and hepatitis C antibody testing. They also had STI screening in the form of syphilis and chlamydia and gonorrhea from the rectal region, from the rectum. Patients had a repeat HIV antigen antibody, so 4th generation test at each follow-up visit, renal function at month 1 and month 6, month 12, and STI screening repeated at month 6 and month 12. Patients were followed up with adherence, with questionnaires around sociodemographics, sexual behavior, and adherence questions. Adherence was also asked through electronic weekly diaries, which documented patients' adherence in relation to their exposures. Adherence was also looked at from pill counts at each visit. These are the results. Out of 381 patients who were screened, 50 were excluded because they did not fulfill socio-demographic criteria. A further 109 participants were excluded on the basis that they did not fulfill sexual behavior criteria. And a further 72 participants were excluded on the basis of not fulfilling pre-existing health conditions. They had established HIV infection at the time of screening and established HIV infection at the time of screening, or if they had evidence of renal impairment. Eventually, 150 patients were enrolled into 3 different sites, 50 at UMMC, 50 at the Red Clinic, and 50 at the community-based organization. 56% were of Chinese ethnicity. Majority of patients were 55% were between the 26 to 35 age group. This was a highly educated group. 77% had a diploma, a degree, and 84% were employed. Of the existing risk factors prior to enrollment, the most common risk factor that the participants reported was having had unprotected sex with a partner who was known to be HIV positive or of unknown status. This was followed by the use of substances for the purpose of sex in about 84% of participants. The majority of participants had either 1 or 2 risk factors, HIV risk factors, prior to enrollment. This is the slide on retention. Patients had very good retention rates and very low dropout rates. So at month 6, 96.7% of patients were retained in care, and at month 12, 92% of patients remained in care. Reporting specifically on adherence, this is self-reported weekly adherence from diaries, from the electronic diaries, and this was based on 73% out of 7,569 diaries throughout the course of the project. So 87.7% reported taking all 7 doses per week. But when we look specifically at the number of doses required for protection within MSM, so that's 4 doses per week, 98.6% reported taking 4 doses per week. Looking at sexual risk behavior, there was an increase in the number of sexual partners in the first 3 months, and this peaked at about 6 months and then followed by a decline and then sort of leveled off, what we call a honeymoon effect. This also mirrored the rates of condomless sex, not shown on this slide, which also showed this initial increase and then subsequent decline. It is worthy of to note that the number of sexual partners, although it increased within the first 6 months, was not considerably very much higher. So it's 5 sexual partners in the past 3 months. Condom use did decrease over the period of the study, as those reported never using condom use was higher than that at baseline and was also statistically significant. Looking at adverse events, and these are self-reported medical conditions during the first month after initiating PrEP. These were mainly gastrointestinal nature and most reported diarrhea. These visits were present largely made within the first week of starting PrEP and were not subsequently reported thereafter. Kidney function monitoring did not change. Kidney function monitoring did not reveal any change in mean eGFR over the period of follow-up. 2 participants, however, had to stop PrEP during the study because a reduction in eGFR of less than 60. However, this largely occurred in patients who had pre-existing risk factors for chronic kidney disease and were largely related to creatinine supplementation at the time. And when this was addressed and stopped, the GFR often returned to pre-baseline normals. It's also worth noting that these patients had a low baseline eGFR to start with. Looking at sexual transmitted infections and HIV, it's important to note that the number of participants reporting any STI at baseline was very high, so 47%. This increased to 49% at month 6 and then decreased to 29% at month 12. So very high rates of baseline STIs preceding the initiation of PrEP. This was highest in chlamydia within the anal or rectal region. So 28% at baseline had largely asymptomatic rectal chlamydia, and this decreased to 13% at month 12. Very few hepatitis C infections. In fact, there was only one hepatitis C infection at month 12. But most importantly, there were no HIV infections after 12 months of follow-up in this cohort, when you would expect at least a 5 incidence rate within this high-risk population. Chemsex and receptive anal intercourse were significant predictors of STI positivity on multivariate analysis. So in summary of the study, 150 MSM was successfully enrolled at 3 different PrEP service delivery sites. Majority were Chinese, young and well-educated, employed and very high risk of HIV infection. Retention and drug adherence were very high, exceeding international standards, and only minor changes in sexual risk behaviors were observed. Decreases in kidney function below GFR threshold of less than 60 were associated with the use of creatinine supplements. Looking specifically at the CBO-based part of the study of the PrEP-based delivery at the CBO site, some of the advantages and disadvantages are listed in tables. Some of the advantages of using a CBO as a PrEP delivery site are that it delivered a very much client-centered care. They know the market as they are. The market is trusted by key populations. They were the first site that completed the enrollment in the MyPrep study, and they were able to offer more flexible opening hours. But like with any other CBOs within the region, they suffered from limitation of resources, particularly when it came to laboratory support, a lack of recognition and certification of CBO staff as potential PrEP providers, and medical legal issues around demedicalization of PrEP. Some of the lessons learned from the MyPrep demonstration project included: PrEP, we know, is a powerful biomedical HIV prevention strategy. No HIV infections were reported in the cohort. The messaging of safer sex in the era of PrEP need to change also to reduce stigma. It is likely that over time, because participants or patients in general who are taking PrEP perceive that they are protected by PrEP, rates of condomless sex are likely to increase over time. And therefore, the messaging of safe sex in the era of PrEP need to evolve so that patients are not shamed or stigmatized by healthcare workers for not using condoms if they feel adequately protected from HIV by using PrEP. It's important that PrEP be framed as a positive and responsible option to remain HIV negative, and that PrEP users are taking control of their sexual health. So positive rebranding. Interestingly, also, chemsex users should be a priority population for PrEP. At least 40% of the participants reported using substances in the sexualized context, mostly crystal meth. But despite this, chemsex use did not appear to impact on overall PrEP adherence. The preferred and most accessible sites for assessing PrEP, if all other factors were equivalent, was the private clinic and the community-based clinic. So certain HIV treatment clinics, such as UMMC, in the long term, in the initial stages, may be early adopters in providing PrEP, but these are not the sites that key populations want to come to unless they have to. Okay, and that when we think about service delivery models, it should always be community-based and key population-led or involved. PrEP is an opportunity for STI control and prevention. As mentioned, there was a high prevalence of baseline STIs which preceded initiation of PrEP, most of which were asymptomatic, reinforcing that we are indeed reaching those who are at high risk of HIV and STIs, and emphasizing the importance of regular screening of STIs extragenitally and syphilis within MSM, irrespective of whether they have symptoms. We need to talk more about on-demand PrEP because the patients want options to taking daily PrEP, and we need to start looking at PrEP stigma, which was not assessed formally in the study. Some of the emerging PrEP service delivery models that are occurring in Malaysia are mostly centered around private clinics, and this is largely because the Malaysian AIDS Council and Malaysian HIV Association initiative has largely been directed to increasing PrEP prescribing and dispensing from the private sector. So as of August 2020, and this is information obtained from the PrEP locator, Google Analytics. Mostly PrEP is being dispensed from private clinics and mostly private GP clinics, and this is followed by some, not a huge amount of primary care clinics, some infectious disease clinics, but patients are not necessarily coming to them. And this is providing PrEP to less than 2,000 patients nationally, and mainly within urban areas in Malaysia. Now, looking at considerations for scale-up of PrEP, guidelines. We always need guidelines, and inclusion of guidelines help with the scale-up of PrEP. We've had guidelines, both pre-exposure prophylaxis and non-occupational post-exposure prophylaxis guidelines, included in the National HIV Guidelines since 2017. These are 2 chapters and they're nested within the HIV guidelines. These have been recently updated, but as far as I'm aware, not online at the moment. And they include updates on guidance on on-demand PrEP. They have mentions of same-day PrEP and greater emphasis on STI screening. HIV Connect was, as mentioned earlier, a Malaysian AIDS Council and a Malaysian HIV Association initiative to increase PrEP providers within the private sector. This has been done in collaboration with the Malaysian Medical Association, Association of Family Physicians of Malaysia, and Malaysian AIDS Foundation. The aims were to provide modular training through online modules, followed by face-to-face training and workshops, subsequently, and finally a brief clinical attachment stage to complete the training. Following completion of training, the GPs get certificates and CPD points and are given the option to register on a PrEP on a national web-based directory of PrEP providers called HIV Connect. The problem lies in that a lot have enrolled, more than 50% have completed the online modules, and even a smaller number have attended the workshop. And so there are current ways of trying to look into how we can simplify this for private GPs so that become more interested in not just starting to prescribe PrEP, but continuing to prescribe PrEP. The MyPrEP Locator is a national directory of PrEP providers, and this was done basically in response to the request for providing a national web-based directory of PrEP providers. So what are the next steps? The next steps are essentially increasing community-led PrEP services in collaboration with family planning, a formation of national PrEP task force, strengthening linkage of PrEP providers, HIV Connect, MyPrEP Locator, and HIV differentiated services for key populations. A lot of emphasis needs to be concentrated on PrEP demand generation activities, including the use of community PrEP ambassadors and influencers, increasing the functionality of the MyPrEP Locator, more competitive PrEP procurement, but not forgetting working with the government to strengthen government commitment and setting of national PrEP targets. I'd like to just conclude by saying that PrEP is, there's an urgent need to prioritize PrEP as an HIV prevention tool. We have made some progress, but it has been slow. We need to address concerns around risk compensation with all stakeholders and frame PrEP in a positive way. I think the way forward is community-based, key population-led involved clinics, but we will require regulatory policy and reimbursement to allow it to make it sustainable. Community empowerment, advocacy, and leadership must drive PrEP access, and future work must look into implementation research in other key populations, online models, and we need to start monitoring our PrEP services. I'd like to acknowledge my various collaborators and everyone who's done most of the work, PrEP-related work there, and the funders, including WHO, UNAIDS, and the providers of PrEP, Hetero and CIPLA and Medispec. Thank you very much.
Thank you very much, Iskandar. Let me ask the first questions, and I encourage our viewers and listeners to ask questions in the Q&A chat box, if you could. Now, yeah, I concur with you, Iskandar, that I think we really need to speed up PrEP implementation. Do you think it's for lack of knowledge and demand that we're not seeing as many, even though you and the rest of our colleagues have opened up more avenues for PrEP around, at least in urban settings?
Thanks, Prof. Adiba, for the question. I think in terms of thinking about it, I think demand generation and awareness of the community probably could be improved upon. And a lot of our PrEP initiatives, which we are subsequently thinking about, include thinking about activities of how to increase demand. The problem that we've had so far is some of the very successful PrEP messaging that we can look towards, so such as Thailand, such as the Philippines, have a lot of visibility to it. And I think we're still trying to deal with a lot of issues around PrEP stigma. So there's so much that we can make visible PrEP to the population at large. So what we've been largely doing is looking at various online models of trying to increase awareness amongst the population. But this is certainly areas and work that we understand that needs to be more invested in at the moment.
Okay, thank you. There's a question from Jean-Michel asking about intermittent PrEP and how would you approach that in the context of the Malaysian setting?
Thanks, Jean-Michel, for the question. Absolutely, I think it's time to certainly think about it. WHO guidelines came out with on-demand PrEP guidelines in 2018 or 19. So there are clear guidelines outside from WHO. Also from the PrEP demonstration project, beyond 12 months after we followed patients, we found that given the option, a lot of patients prefer to take intermittent or on-demand PrEP. I think it tends to occur mostly in patients, in clients who have infrequent sex and therefore don't require to take a pill every day to protect themselves. So I think the PrEP portfolio, or how we offer PrEP service deliveries, ultimately is following very much how we offer contraception. And that includes the more options we have, the more likely clients are potentially willing to take up PrEP. And also within the current guidelines that are due to come out, the Malaysian guidelines, there is a specific mention of on-demand PrEP. And so as an attempt to increase uptake of PrEP in this way. And also above anything, it reduces cost in areas where PrEP is a bit more expensive.
Okay, one final question from me. I guess also in relation to intermittent PrEP, but following on the results of HPTN 083 and 084, which is, I guess, a lot less relevant to us because of the gender issue. Do you think we should already be preparing and seeing the acceptability and the preference for injectable long-actings in Malaysia? I mean, I know we haven't even really got off the ground with tenofovir, but should we be thinking ahead and be preparing, those at risk for what could potentially be, an easier, in inverted comma, way of delivering PrEP?
Yeah, absolutely. I think we need to start those discussions. The injectable PrEP or injectable cabotegravir doesn't just affect prevention, affects treatment, and so therefore, I think as a region, as a country, we don't want to be left behind in terms of those discussions, in terms of access to better and drugs for people who are not able to take a daily pill. But we certainly have to get, I think, our act together as a country in terms of trying to improve access to PrEP as a whole, because if we don't, we can't have those discussions about injectable PrEP, and then we stand to lose out in the long term. But no, I think it's very important to have those discussions. I think as a region, we need to have those. It's important for those discussions to be had so that we can have access to injectable PrEP. Yeah, certainly, I agree. Yeah.
I beg your pardon. Suddenly the questions have come up, thick and fast for you, Iskandar. Let me just choose one or two, and then perhaps Iskandar can answer the questions more directly. There was. Okay, here's a question. Should we be thinking of opportunities to expand PrEP through pharmacies?
We haven't looked at that. I think, and throughout discussions about rolling out PrEP in the country, we haven't really included PrEP dispensing from pharmacies per se. A lot of the models that I am aware of are based in the US, and they've had some successful models there. But the models from pharmacies are largely inclusive of everything from HIV testing to counseling to PrEP dispensing and potentially follow up as well. And I don't think with the pharmacy setup that we have at the moment, they are willing or able to take that on. So I think if the setup is there where pharmacies probably get some form of reimbursement for doing that, and they're proactive in terms of doing activities beyond just dispensing, then I think it's a model that could potentially work. But it's not a model that I think we have explored within our setting.
Okay, one last question, because it's a very important question from Hazrik. When it comes to rolling out these services, I'm aware of certain medical practitioners and frontline workers that involve their own personal beliefs when providing these services, e.g. preaching to MSM, trans individuals, etc., that these behaviors are unacceptable. And this can strongly affect the hesitancy of individuals to access these services. So what do you think can be done to stop this?
I think this is always going to be a big battle within conservative societies, but not even in conservative societies. The UK suffered from, and it is a country where you wouldn't have expected very much PrEP stigma. They suffered in terms of not being able to dispense PrEP from the National Health Service for a very long time. We have been here before, so when thinking about issues around and concerns around PrEP causing risk compensation or PrEP stigma because of concerns that PrEP may encourage unsafe sex or condomless sex, we've been, so just to give you a couple of examples, we've been here with antiretroviral therapy, we've been here with HPV vaccination, we've been here with the oral contraceptive pill. At the time of rollout of all these interventions, the same issues were considered in terms of concerns around clients or patients who took these interventions that it may encourage more unprotected sex. I think ultimately it is about stigma, and these discussions have been had many times around how we as a society put moral judgments on how people should be intimate. You know, and I think more discussions need to sort of contextualize the stigma around how we morally judge other people around having sex. And I think if you take that into the equation, then you may be able to find a solution. But ultimately, PrEP is all about reducing HIV infections. It doesn't pretend to be anything else. And if you tackle it just like harm reduction, which essentially is what it is, it's a harm reduction approach to preventing HIV infection, and take it from a public health approach. And if you can convince policymakers and healthcare providers to do that, then at least you've won on that occasion.
Okay, I've been repeatedly reminded that we're going way over time, and thank you everyone for posing those questions to Iskandar, whom he promises me that he's going to answer all of you online. So we need to move on to our final and last but not least speaker, Michael Cassel from Vietnam, who will be giving us a lecture on seeking the silver lining, differentiated HIV services for safe, sustained connections through COVID-19 and beyond. Thank you, Michael.
Good evening, everyone. Thanks so much to IAS and to Saria for the opportunity to learn from and join in this conversation. Today, I'm Michael Cassel. I work on the global linkages and EPIC projects with PEPFAR and USAID support, and I'll provide a little bit more information about where we work and what those are on subsequent slides. As others have noted, between this meeting and the last one, we've obviously had a fairly devastating, disrupting event happen, COVID-19. And I would like us to just try in this talk to focus a little bit on some of the potential silver lining related to COVID. Now, I say that recognizing full well, it's very difficult to even conceive of a silver lining. We've got almost 60 million cases globally since the last meeting. We have almost 1.4 million global deaths, still expanding epidemics in many countries, including the US, and huge continued risks of disruptions to HIV and other essential health services. But hopefully now some promising vaccine candidates on the way, some notable successes in curbing COVID-19 transmission in some Asian countries. And in particular, when I'm thinking about sort of the potential silver lining, I'm thinking about this notion that we've all known for some period of time that differentiated service delivery was a key to addressing the HIV epidemic, and that if we were going to close gaps for more than 7 million people living with HIV globally who still don't know their HIV status, or for people who are not accessing treatment or virally suppressed, that we needed to open up new service pathways and channels. And I think one of the things that COVID has done, among the many horrible things that it's done, is it's potentially accelerated differentiated service delivery in a number of countries with respect to HIV. So I want to talk about that thematically a little bit on the next slides. So just conceptually, and perhaps oversimplifying a bit, but just an example from HIV self-testing. We've known for a long time that HIV self-testing is safe and effective. We haven't seen it rolled out broadly to the extent that I think many of us would think would be useful in terms of achieving epidemic control and addressing client preferences and needs. But we've known that in particular that it's perceived as a confidential, convenient, and discreet way for people to access prevention and treatment services without necessarily having to go through facilities or community organizations and other ways and preserve their confidentiality. And now with COVID, also potentially to mitigate the COVID-related risks of exposure by interacting with other staff in the community or with clinical staff and facilities as well. So under these two global awards, and in particular the EPIC award that we work on, we were asked by PEPFAR and USAID very early on in the COVID epidemic to be thinking about, well, what are the strategic priorities to be able to mitigate the impact of COVID-19 on HIV, and in particular to prioritize sustained service delivery for PLHIV. And so we immediately thought, of course, about a differentiated service delivery model, and thought about a model that would reflect these three core pillars with a focus on a person-centered approach. And the person-centered approach being both clients and also providers, and how we can make things safe for them. So the three pillars, of course, in the red and the blue and the purple here, safeguarding providers and beneficiaries from COVID-19, supporting safe, sustained service connections, and monitoring and improving client outcomes, and looking at differentiated channels to do all three of these things. So I'm just going to highlight here on the following slides some of the resources that we, in partnership with UNAIDS and the Global Prevention Coalition and others, came up with as elements of strategic response to mitigate COVID-19 impacts on HIV programming, particularly for key populations. So certainly decentralizing services to limit COVID-19 exposure, multi-month dispensing of ART and PrEP, going online, navigation support, self-led services, including HIV self-testing, safeguarding community and clinical services, so really thinking about virtual training and capacity building for providers and protecting providers, and then making sure that they were in a position where they could still safely provide services to individuals with greater needs, hotlines and virtual navigation for clients, delivering commodities where possible, including HIV self-test kits, condoms, and other things, and then tracking progress and pitfalls over time so we could actually identify where there were issues and move forward quickly to mitigate and address them. And then early on, some messaging guidance. You can see the date on this was April of 2020, but really trying to help people to understand what the risks were of COVID-19 exposure, how they could manage those, and how they could safely still access HIV services. And this messaging guidance really focused on both providers and clients to help make sure that we had safe, sustainable channels for people to access services. So while we were developing all this guidance, of course, we were also implementing. So I referenced these two programs, so EPIC and Linkages, implementing in a variety of countries around the world, which you can see here on the map, 12 in Asia in March of 2020, which was really when COVID-19 was starting to ramp up, and there was great concerns about continued spread of COVID-19. And so I just want to share some of the experiences from implementation in countries largely in Asia related to this, to the COVID-19 pandemic. So here you can see some of the impact of COVID on HIV testing trends. These data from Eswatini and from Liberia, but again, consistent with what we would see in a number of other countries as well. You see the first confirmed cases, you see some drop off in HIV testing uptake. When you see there's lockdowns, you see even further drop offs in HIV testing uptake, unsurprisingly. And of course, this doesn't just apply to HIV testing. This example from Liberia, looking at viral load coverage, where we see drop-offs in viral load coverage as we see lockdowns related to COVID-19. We've even seen some countries actually suspended viral load testing under COVID until they perceived it was safer for people to access viral load testing. And you see here, even surprisingly, this decline in the proportion of people who got viral load being suppressed, which seems to be associated with lockdowns and COVID-19. And here, we think what we're seeing here is that what happened is that clients who had greater need for viral load, in the sense that there was suspected lack of suppression, were still accessing viral load, and that's why you see those higher rates. But it's hard to explain exactly what's going on there. But again, across the cascade, some measurable impacts at the program level. So to go forward, we needed to, of course, then implement a variety of different approaches, including, sort of first and foremost, opportunities for self-led, self-care services among clients, and in particular, no contact outreach and referral, as you see here. So this example from Jamaica, in which case we basically had an online reservation platform and online messaging platform that individuals can reach anywhere on their mobile phones. And this was helping them to triage their COVID-19 risks as well as their HIV risks, and then to be able to safely either order or access services online, or be able to book appointments to safely go in and access services. So here in Thailand, you can see across the bottom a timeline of sort of the COVID epidemic in Thailand and some of the lockdowns and relaxation of lockdowns across the bottom, mapped against prevention program coverage and testing uptake week by week. And the thing I really want to focus attention on here is the yellow and the green lines, which are basically the increase in online to offline, that's what the O2O stands for, reservations, and online to offline appointment arrivals. As we really started to see COVID ramp up in Thailand, we also saw increased use of this differentiated access platform. Similarly, in Thailand, for PrEP, what's very interesting actually is there was a big push, of course, prior to COVID to scale up PrEP and continue Thailand's sort of global leadership in terms of expanding access to PrEP, which has taken place prior to COVID. And remarkably, even during COVID, there still was an expansion of access to PrEP over time. Part of that related to being able to access services online. Part of that also related to some innovative approaches, including an express approach, which basically allowed clients to online do some of the pre-enrollment work for PrEP virtually, and to be able to have shorter duration initiation appointments with lower risk associated with those, so they could sort of get in and get out quickly with their PrEP, and that we actually saw an increase in PrEP uptake from Q3 versus Q2 associated with this online service promotion and the PrEP Express model in Thailand. And then, of course, a major focus on being able to provide virtual navigation support, client-centered follow-up, case management support across the cascade, whether it be prevention, treatment, viral load services, helping people to figure out where they could safely access drugs and services, as well as to provide whatever kinds of emotional, social, and other support that they might need online, if possible, confidentially. So in Thailand, again, an example of how some of this proactive case management may have helped to mitigate some of the COVID-19 impacts. In the top left, basically what you're seeing is that 90% of the individuals who are identified newly as HIV positive were actually initiated on ART because of some active follow-up using SMS messages and a variety of other approaches to fast-track treatment access. And the bottom, for people who are already accessing ART, expansion of multi-month dispensing, so that you actually saw more people over the course of the expansion of COVID-19 accessing either 3-month or 6-month MMD than the previous period. However, in an example in Vietnam, again, a lot of support through programs to the national program to try to expand multi-month dispensing, to have systems in place to be able to manage stock, to be able to facilitate multi-month dispensing. But even so, global shortages really pose some challenges to the expansion of MMD. And these supply chain challenges really created some issues in terms of being able to sustain access during the period of COVID, as you'll see on the next slide. So here we can see there was really a second wave of COVID-19 that started basically at the end of July, beginning of August in Vietnam, and we start to see that, unfortunately, the stock issues coincided with that, and we start to see less MMD dispensing on the left-hand side during that period of the second wave, and then predominantly on the right-hand side, that being related to ART stock issues, and particularly in Ho Chi Minh City, which is obviously a very populated site with lots and lots and lots of clients, so that's very unfortunate. So that really forced programs to think creatively about, yes, in the process of expanding MMD, how are we also going to be able to keep people in contact with their medicines, even if we have stock issues? And so then that facilitated a lot of dialogue and discussion about alternatives, differentiated alternatives, including home delivery. So here, an example from Indonesia about leveraging the existing network of courier services that already sort of are the lifeblood of Jakarta, to be able to safely and confidentially deliver ART to folks at home. Supply chain issues here too were constraining multi-month dispensing, so home delivery really became an imperative. And then this was developed in close partnership with the national program, so there's joint advocacy about being able to do this and have it all be reflected as part of the national program and move forward in a sustainable way. Here on this slide, again, this wasn't limited to just Indonesia. We also were doing support for home dispensing in Jakarta, in Nepal, and also in Laos, which is not depicted here just because the numbers are smaller in terms of the treatment cohort. But in both Jakarta and Nepal, you can see very precipitous increases in the cumulative patients receiving home delivery by the end of August. 40% of patients at eligible at supported sites in Jakarta, and 36% of patients at supported sites in Nepal by the end of August. So dramatic uptake, and hopefully having an impact on people sustaining their access. Again, in these three countries, and I think even more broadly elsewhere, a differentiated approach was important, not just in terms of thinking about opening up new pathways for access to ART, but also in terms of how you would actually do something like home delivery. So Indonesia had the courier services, but Nepal and Laos really focused on robust community support systems. And Laos modified its home delivery to really focus on settings that were preferred by clients, given that there were some concerns of confidentiality of having drugs dispensed at home. So they could, for example, find another convenient close location and have them delivered to them there. And again, all of these programs are looking at costing and other analyses to really try to think about what's the cost of the differentiated approach and what's potentially the savings of the differentiated approach. So I would say just watch this space. So in sum, just wanted to highlight, going back to this notion of the silver lining, again, hard to find, but in places where there are differentiated services, probably more robust capacity to respond to COVID. COVID indeed may have driven differentiation in a lot of settings, and then sustaining this acceleration and innovation is probably key to closing epidemic control gaps going forward. So if we could possibly build on some of the momentum that COVID gave us to differentiate, that would be helpful, because we knew we needed to do it anyway. And so it would be great to make sure that we institutionalize some of these innovations and continue this momentum going forward. Again, thanks very much. I think that's time, and I really greatly appreciate the opportunity, and welcome any questions. And this is a link to the resources that I referenced earlier.
Okay, thank you very much, Mike, for that extensive coverage of the responses in different regions to the COVID-19 pandemic that has severely disrupted our HIV programs. We have time for one question, and that was, there's a poll here. Okay, We'll move to the poll. Sorry, Mike, you might, if you don't mind, answer the question online. There is
I've done that. That's great. Thanks.
Oh, you have? Okay, great. So we'll invite our participants to a poll on Mike's presentation. Which of the following reflects the impact of COVID-19 on the response to HIV in Asia? And there is no one right answer. It's a quiz. Okay, so we have
Thanks everybody. Thanks, Adiba. Can I comment on the poll? Is that okay?
Yes, please.
So first of all, thanks to everybody for participating. I'm surprised we found time for the poll, so that's great. I guess my quick reflection on the poll is I would have answered it pretty much exactly this way. And I think that's great. I was nervous about looking for the silver lining, because again, COVID really truly is devastating, and it's hard to find a glass half full or any positive impact of COVID. But I do think, and it looks like a number of the people who have been participating today agree, that it's also compelled us to move forward, potentially with some innovations that we hadn't thought of before, and potentially with some innovations like multi-month dispensing that we knew we needed to do anyway. And it really pushed us in the direction of moving forward. So I think, again, we still likely have a long road ahead with COVID in a lot of countries, a long road ahead with HIV in a lot of countries, but looking for the opportunities for synergy and really trying to build off what we knew we needed to be doing and what we see as, I think, our strengths as a community right now, to close those gaps for people who are still being left behind by offering new approaches and new channels. And if we can have those be safer channels, then that's also going to help us be robust and resilient in the face of COVID. Thanks.
Thanks, Mike. I'm going to take the chair's prerogative and ask you the last question. We obviously see the huge need to move digitally, but do you think this is going to create an even larger divide in terms of access to technology?
Yeah, that's a... Sorry, I'm turning on my video because I was asked. Hi, everybody. Adiba, it's a great question. And actually, I would love to hear your insights on this as well. But I will try, since you asked me, to answer that to the best of my ability. You know, when we talk about a differentiated approach, it's not prioritizing necessarily one thing over the other, in my perspective. The idea is we have already the vast majority of people living with HIV globally are already on treatment and virally suppressed. And that's a huge accomplishment that everyone should feel very proud of. And it's because the current solutions are working. We're not going to stop all of those other solutions. We're also just going to try to open up new channels that may be preferred for people for whom those current services aren't working. So, you know, I think anytime we introduce a new innovation, there are people who are going to appreciate that and want that. And I think we're seeing massive demand for self-care and a desire for self-care because of confidentiality, convenience, and all the things that we've talked about. For some people, that's still not going to be what they want. And that's okay. We just need to make sure that we address that. And I think it's the same when we think about specific areas that were covered today, like HIV self-testing, differentiated approaches for delivery. So thinking about, you know, pharmacy channels might be the right place for a lot of people. Those might be fee for service. So fee for service is not going to be right for everybody, but that will work for some. And we need to make sure that there's solutions and pathways that work for others that are maybe free and more accessible to them. So again, no magic bullets, no one size fits all solutions, but thanks for the questions. And I'm sorry, that's probably not a great answer to the question, but that's just my quick reflection.
Thank you, Mike. Thank you. There's plenty to discuss, and hope we will be able to provide that avenue further. Now, my Swiss colleagues, whom, as you know, being on time is very important. So I will have to wrap up now. If you leave it to me, the Malaysian will go on and on. It leaves me to, on behalf of the IAS and all my and all the speakers this afternoon, to thank all of you for participating in this virtual event, especially during this very busy period. Thank you for the questions that you've posed to everyone, and I hope you found the session and the presentation stimulating. We encourage you to share the recordings of these sessions, which to those who've not been able to participate, which we will make available on the IAS Educational Fund webpage in due course. As you know, the aim of this meeting was to help narrow the gap between the latest scientific advances on HIV and their implementation, and we sincerely hope we've achieved that this afternoon, and also inspire ourselves to take more action to reduce the gaps between scientific advances and implementation, particularly here in Southeast Asia, where, as you may have heard in the last few days during the World AIDS Day commemoration, that we're lagging behind. This IAS Educational Fund webinars have been made possible through support from Merck, Sharp and Dome, MSD, and the Swiss Agency for Development and Cooperation, the SDC. So we hope to, at the IAS, we hope to, provide many more of such events. And it's very important for us to get your feedback so we can continue to improve on these sessions. So once again, thank you very much, in particular to all our speakers and all of you for staying on. See you at the next IAS event. Bye-bye.